based on this sort of work, do you think that the pathobiology of all cancers will be cataloged and the molecular drivers will be understood in our lifetimes?
Well, that's certainly the rationale behind TCGA, and I don't think it's a terrible rationale. I think there are always going to be unknowns. There are going to be classes of cancers that, at least at first glance, don't fit into this paradigm. But I think that the impulse to do deep genotypic analysis and epigenomic analysis on every cancer is the right approach. I think that we are going to be able to catalog increasing numbers of these, and that catalog is going to be basically to mix metaphors, a roadmap for therapy.
So if that's true, and this is kind of a so if cancer is, do you believe that cancer will be managed as a genomic science and genomic medical discipline? And from your position as Dean of Academic Programs at Harvard College, who and how are the practitioners of the future going to be trained for this? Because right now I don't think they get more than maybe 2 hours of genomic training, or some minimal number of hours?
That is a great question. It's a workforce question. And I do believe, to answer the first part of your question, that this is a genomic disease. This is a disease of genes. And the more we understand that, the sort of more comfortable we get in thinking about how trials should be performed, how treatment intervention should happen. But I think you're absolutely on the money when you say that current practitioners haven't been given sufficient training to understand the nuances in a disease like this that is still very complicated. And I think that there are two workforce issues here. One is the training issue. I think that that's easy. We can implement sufficient genomic training based on what we understand today in medical schools and in residencies, and I think there are a lot of programs going forward there. Where there's a huge need, and I think that there may be some commercial solutions here, is in training practitioners who are already in practice. When we talk about returning these results, and this is just cancer, the sophistication required to understand the implications of these results and what can I act on, what can I not act on, what is significant, what's not significant. Most practitioners are really ill-equipped to handle this kind of information. And in national committees that talk about rules around return of results, this is a major concern. How do you return results in a way that are understandable by a practitioner? And as bad as OncoMap is, whole exome and whole genome sequencing is just going to be that much worse. So I think that there is an opportunity somewhere for postgraduate training focused on this.
So that kind of leads me to the next thing is, we're talking about the Dana-Farber, which is on the cutting edge, and
you bet it is.
Yeah, but and the general media and genomics industry does focus on 50 or so NCI designated comprehensive cancer centers, but it's our understanding that 85% of the burden of cancer is met by other providers out in the community. Where is community cancer care today? Where is it going? What technologies allow us to do what you're doing here in that part of the world?
Well, I think that's the space that Foundation is trying to fill. And I admire them for doing that. Where I see, I think that any practitioner out in the community can, with their pathologist, get a piece of tissue and send it to Foundation. I think that the real challenge is in the interpretation. And how do you actually act on this? It's simple to send a test off. It's really difficult to understand deeply what a test means. I don't have an answer for this yet, but obviously to improve cancer care throughout the nation, this information has to be pushed out to practitioners. We can't, you can't, the implication of your question is, can you only do this in NCI designated cancer centers? That's going to be a recipe for failure.
So if we have a therapy-directed test that's out there, but the therapy now costs well over $100,000, is that a sustainable model?
Well, absolutely not. Absolutely not. And I don't have a solution for this yet. I don't have a solution, anybody has a solution for recouping major R&D expenses for developing biologicals that cost $100,000. But I think that pricing structure is unrealistic. And all the pressures, obviously, are combining to reduce that cost. And what are the implications? Are the implications reduced R&D? Are the implications that patients aren't going to get the drug? I don't know that yet, but no, I don't think that pricing structure is sustainable.
So based on the things that you talked with, how we're looking at pathways, if there's a drug that's on the shelf that might be a generic, if a trial is done that shows that generic now affects that pathway, does that now obviate the need for the $100,000 drug?
In that scenario, if it's exactly as you described, it certainly does. But I think you have to, I think we have to still be evidence-based. And there has to be a trial somewhere that compares that generic small molecule to, Genentech's expensive biological and demonstrate equivalence.
But what you've described here actually enables that to
Yes.
take place.
Yes, but it's not a substitute.
It's not a substitute.
We have this argument internally all the time. I gave you the example of finding a BRAF mutation in a kidney cancer. I have colleagues who say, screw it. You know what BRAF does. This is a cancer. Give the patient vemurafenib. And I'm on the evidence side and say, no, you really don't know until you actually do the trial. But you're right. This is a resource for getting the trial done quickly.